Good afternoon and welcome. My name is Jerry Williams. I'm the founder and president of MSU, Myositis Support and Understanding, a patient-centered nonprofit organization, and I'm also a myositis patient for the past 16 years. Today, to help us kick off Myositis Awareness Month, we are honored to have one of the myositis experts, Dr. Lisa Christopher-Stine. She joins us to discuss the evolution of the polymyositis diagnosis in light of recent research. Our theme for Myositis Awareness Month this year is Myositis in Focus. And today, we are putting education about polymyositis in focus. Dr. Lisa is an associate professor of medicine and neurology and is the director of the infamous Johns Hopkins Myositis Center in Baltimore, Maryland. She truly is one of the myositis experts as a researcher, clinician, and educator, and the many other things that she's involved in. Dr. Lisa, we welcome you and thank you for joining us live today.
Thank you so much, Jerry. It's a pleasure to be with you today. I'm very honored and privileged to do so. I've subtitled my talk, Polymyositis, a Rare Disease, and hope to tell you why that might be true. I've also left, hopefully, a fair amount of time for discussion because I think that the questions you raise are sometimes some of the most important things that are on your minds and that can help others. So with no further ado, admittedly, I apologize for the technical delay and the fact that I've just made it back from the dentist, but here we go. These are just disclosures of what I do outside of being and related to being a physician. So the objectives today that I'd like to do, I'm going to give you a talk as if I would give it to my colleagues, but I'm happy to also back off and explain anything that is less clear. Those of you who have seen me in practice know that I'll speak in medical terms and then I'll try to tell you what that means from a layman's perspective is the way I would want to hear it as a patient. So the first thing we'll do is to review what's called the Bohen and Peter Classification criteria. I know I have a wide audience today, and what I'm so impressed with when I meet all of you as patients and at the conference is the level at which you've read about these diseases. They're rare, and you're a very educated group. I won't take any liberties. However, I do know that many of you could probably give this talk to some extent, that you are that well-read with regard to these diseases. So the Bohen and Peter classification criteria are a scientific way or a classification criteria system that are 40 years old, 40 plus years old. And dermatomyositis is also part of that classification criteria. And we'll examine the updated classification criteria for these two diseases and how they compare and why. I would next like to examine the concept that I've subtitled this talk, that true polymyositis, depending on how we think of it with regard to semantics, what do we really call this, by itself is probably quite a rare phenomenon, especially in the absence of an autoantibody, which we'll also discuss. Okay, so these are the laundry list of myositis as it relates to an autoimmune phenomenon. So myositis, really backing up, myo is muscle and itis is inflammation. So technically any inflammation of the muscle is a myositis. For the purposes of this group that you're a part of and the purposes of my clinical practice and my research portfolio, I concentrate on the autoimmune varieties and their mimics. So we'll talk about the mimics of the autoimmune myopathies, or what we call idiopathic inflammatory myopathies. You'll sometimes in some medical literature see the abbreviation IIM, and that's what that stands for. It's much easier to say myositis. So for the purposes of going forward, we'll make the assumption that the myositis we talk about is the autoimmune variety. And when I went to medical school, it was classified as the following. Myositis was largely classified as polymyositis and dermatomyositis. And then there is a third category there, inclusion body myositis. And again, just because the group may be quite diverse, just as an aside, inclusion body myositis is likely the most common subtype of autoimmune myositis. And it is debated as to whether it is indeed autoimmune. It does not seem to respond to traditional immune suppressants most of the time. However, some people have some features of IBM or inclusion body myositis, which we'll abbreviate as IBM, and polymyositis. So we can talk a little about that. The fourth guy on the list is IMNM, sometimes called NAM or NAM, and Jerry and his wonderful group has been diligently providing and scaling down literature for the members of this group to try to understand these subtypes. I'm actually very impressed with the literature that I've seen to date in this regard for this group. So what is this giant term, immune-mediated necrotizing myopathy? I'll go over that today as one of the most common mimics, or what we really used to probably lump that into the subcategory of polymyositis. And I'll try to explain that to you from a pathologic basis. What we see under the microscope, that really is the hallmark of what differentiates it from polymyositis. And where that may matter is the way we treat it and follow it up, and perhaps even some of the associated risks. That's still being borne out, but I'll try to make some comments as to why certain subtypes of that particular myopathy, which can be very hard to treat, may be important to name it as such. And then finally, there are a bunch of other rare myositis syndromes there, and I'll refer you to the very last bullet on my slide, which says myositis related to other connective tissue diseases. As you may know, these diseases are treated by rheumatologists and neurologists. And in our center, I think that's a fairly seamless transition. We've learned from each other, and I think that both of us, both subspecialties, can treat that disease similarly. I've learned from my neurology colleagues about the workup of these diseases, how to read an EMG and a muscle biopsy. I think they, in turn, have learned how to use immune suppressant agents in long-term, on a long-term basis. So myositis related to other connective tissue diseases. Connective tissue diseases broadly refers to other rheumatic diseases that can affect the connective tissue of the body. And when we talk about myositis, the three most common diagnoses in that category are lupus, rheumatoid arthritis, and scleroderma. And most of the time, patients with myositis who don't have a rash might be called polymyositis in this context. And we'll talk about this as well. So this may be one way that someone gets labeled as polymyositis. It may be better to label them as an overlap syndrome, because it's important to note the potential overlapping features of those other illnesses, of which you might not manifest the full complement of that syndrome. For example, scleroderma literally means hard skin. And for patients who have scleroderma without other features of the disease, like the muscle involvement, that's all they may have, is that they may have hardened skin. In fact, our patients who have a scleroderma overlap don't really seem to have as much of the skin manifestations, but may have the more serious internal organ manifestations of that overlap syndrome. Okay? Allotted more time to sort of talk about the differences between the top four of these. Okay. So, polymyositis, dermatomyositis. Let's talk about the way that physicians classify these syndromes. And I'll be clear, this is really for purposes of inclusion in clinical trials and in trying to unify data and studies. This is the other reason it's incredibly important that we are all calling, as physicians across the world and across specialties, the same thing. So for a long time, neurologists were talking about a separate subcategory of necrotizing myopathy, while rheumatologists continued to call it polymyositis. And if you lump everybody into that category in a clinical study or a clinical trial, you risk having incomplete or somewhat tainted results because the sample is not so homogeneous or similar. Okay. So these are criteria, actually the original criteria, this is a review, the original criteria are in 1975, reviewed again in 1977, so we're looking at criteria nearly as old as me, 43 years old, and so they needed to be updated. But what have we as doctors used for years? It's these. Symmetrical proximal muscle weakness. That means weakness of the shoulder girdle and hips. the most common muscles to be affected are proximal muscles closest to the spine, right? So shoulders, hips, and less so distal muscles, those further away from the spine, which would be like our ankles or wrists or finger flexors or toes. Elevated muscle enzymes, and for most of you who are in this group as a patient or as a caregiver of someone, the CK is the thing we speak the most about. That stands for creatine kinase. That is an enzyme that is present in the muscle, but when damaged, leaks into the bloodstream in high levels. It is a little confusing in that not everybody, interestingly, leaks out CK into the muscle. This is usually not true of the non-dermatomyositis syndromes, but a lot of our dermatomyositis patients may have normal CK, and that's a whole other talk for another day. Aldolase is another enzyme, excuse me, from the muscle, and we're not exactly sure either why some people raise aldolase and others really don't. Or some of you may ask me why you have an isolated elevated aldolase, but not your CK going up. Again, there are scientific reasons this may be the case, but we try to look at the sum total of all of these enzymes to make an educated guess as to how damaged the muscles are. There's something called transaminases, and many people will call them liver function tests or LFTs. It's a very poorly termed name in medicine because they're not only of liver origin. They are actually also of skeletal muscle origin. I wish I had $1 for every time a patient came to see me who had a liver biopsy due to elevated liver function tests before anybody checked a CK for them, which is tragic. So and sometimes some of you may have liver involvement with regard to your disease. There can be an autoimmune liver component, but most of the time, those in fact aren't coming from the liver. They're coming from the skeletal muscle. This is also important to know because many of the therapies that we use can irritate the liver, and we want to be able to appropriately assess whether or not there's irritation there. And then finally, there's another enzyme which also can be of liver or skeletal muscle origin called LDH or lactate dehydrogenase. Myopathic EMG abnormalities refers to a specific pattern, and many of you have been through the EMG, I'm sure. So in the typical hands of an experienced person doing an EMG, I always say it shouldn't be painful. I've had it done to feel what it feels like. And an EMG is, in fact, uncomfortable for sure. And depending on people's level of pain tolerance or sensitivity in the muscle, this can be a painful test, I recognize. It's a very important test to help physicians know where there's irritability in the muscle. So something called an irritable myopathy is considered to be one of the main features of myositis. If it is a non-irritable myopathy, that can be consistent with somebody who's been treated for myositis, but their muscles aren't quite normal. But nevertheless, it gives us a clue that something is going on in the muscle. And it's not a nerve problem, it's not ALS, it's not something else that can sometimes mimic these diseases. And then the fourth bullet on that list is typical changes on your muscle biopsy. That's under the microscope after you've had your muscle biopsy. A neuromuscular pathologist with experience in reading this type of biopsy is very important. Who reads this biopsy should be read at a place who reads a lot of them, can tell us whether or not we're seeing the changes that we would predict for an autoimmune muscle process. And I'll actually show you what they look like in a few slides from now. So let's not talk about the rash for a moment. If you have the rash of dermatomyositis, which is not our talk for today, and 3 of the top 4 criteria, you're said to have definite dermatomyositis. But if we take away that bullet on the rash and we talk about the quote-unquote polymyositis, the old criteria would say if you have all 4 of those first things on that list, you have definite polymyositis. You would be able to be enrolled in a clinical trial if you meet the inclusion, if you don't have any exclusion criteria. And this was how we, for decades, diagnosed, quote, polymyositis. You'll notice what's missing there is there's no imaging, no MRIs, and many of you who visited our center know that we really do try to do at least one MRI to take a look at what your muscles look like from that perspective. There's no autoantibodies, which has become the mainstay for us as clinicians and researchers to try to help take care of you, because we try to use those antibodies to predict the clinical features as well as the potential clinical features that may come alongside the muscle disease itself. Say you have 3 of the top 4 of those. Well, that would be a little less specific, and you'd have probable polymyositis. You get the idea. 2 of them, only possible. So you can see that that was what it looked like in the 70s. Fast forward, it only took us 12 years plus. And when I say us, I'm peripheral to this effort. And this is no small feat. This was led by Dr. Ingrid Lundberg at the Karolinska Institute in Sweden, along with Dr. Lisa Ryder, Fred Miller at the NIH, and others, a swarm of others in both Europe and the United States, as well as Asia and abroad, to try to hone in on a better, more complete way to look at these diseases. There is a little online web calculator for physicians to help try to get the probability score. Now, instead of 4, 2, 3 characteristics, instead there are many more, and we try to, and we do use a mathematical formulation to see if there's a probability of at least 55% or greater. Now, can you have myositis and have less than that probability? Sure. There are always exceptions to this, but this was a general predictive tool. And if you look through the categories here, the checklist of items on our newest classification criteria, you'll see that first we look at the age of first symptom, and that's only to say that under the age of 18, we call this juvenile myositis. Over the age of 18, that's a random cutoff, recognizing that the disease doesn't look all that different in children than adults around the age of 18, but it does look quite different with regard to risk profile. Children with the same autoantibodies as adults that might have cancer don't get cancer, for example. And children do seem to get more calcinosis than their adult counterparts of those that have dermatomyositis. Again, another talk for another day. Okay. As you can then see, that idea of symmetric proximal weakness is back on our list, but we are careful to separate it into proximal upper and lower on these criteria. This criteria now includes neck flexors, and we want to see that neck flexors are relatively weaker than neck extensors. Neck extensors are generally preserved in these diseases, and if we see neck extension that's weak, we might be thinking about another neurologic process, so it helps us hone in a little closer. In the legs, the proximal muscles should be relatively weaker than the distal muscles, the ones further from the spine. Again, distal muscle weakness is suggestive more of inclusion body myositis or another process. Now, can you have some distal muscle weakness and still have polymyositis or related disease? Sure, but in general, that's a rule out for us. The next 3 features have to do with dermatomyositis, and those are the specific rashes that made the list. Next, you'll see dysphagia, which is the inability to swallow without difficulty, or esophageal dysmotility. Dysphagia is the person's complaint. Our patients tell us it's difficult to swallow liquids or solids. Esophageal dysmotility is a test on usually imaging, something called a cine-esophagram, or a swallowing study that many of you may have had to undergo to try to see exactly and quantify the level of swallowing difficulty. And this is very common in our diseases. The only antibody to make the list is something called anti-Jo1. Jo, J-O, was named for the first patient that was seen with this antibody, and I believe his first name was John, and that's how that came about. We don't usually name antibodies quite like this and anymore. Why only this antibody? Well, it's one of the most common antibodies. We see this with and without a rash, so it could be part of dermatomyositis or part of an overlap syndrome polymyositis, if we're still using that term. We'll talk about why maybe we shouldn't. But why it's only used by itself in the absence of the other antibodies is that they're not largely commercially available throughout the world. Even in the United States, many physicians, when I speak at conferences, say, how can I get these antibodies? I don't have them available. And when these criteria were being developed, they surely weren't available. So that's changing. And I do think that I've said the parallel that I feel it is as important to know the autoantibody if we can, as it is to know, for example, the sugar level of somebody who had diabetes. I feel like it's irresponsible for us not to try to know that antibody because I think it can help us predict certain risks. And in the absence of an antibody, which sometimes we really just don't see it, it doesn't mean you don't have one, I think what it means is we just don't know it. In the absence of those antibodies, it's a little harder to predict, and we also have a little higher level of suspicion that we should look to rule out exhaustively anything else that might not be polymyositis, for example. You see that the muscle enzymes made the list. And then you see very characteristic features of muscle biopsies for our pathologists. That's what the last 4 features are. The last one there is called rimmed vacuoles. Vacuoles just really means a hole in the muscle and a rim around it that's usually red and characteristic in color when you're looking under the microscope. Those are much more typical of either inclusion body myositis or perhaps another genetic or other reason for, or even a toxic muscle disease that is not polymyositis. Okay, and then you see perimesial, the third up from the bottom, or I don't know if you can see my arrow, but perimesial or perivascular infiltration of mononuclear cells. That's a large medical term that says it's either around the muscle or around, for example, the blood vessel. We're looking for infiltration of lymphocytes, of immune cells from the white blood cells that are very characteristic of these syndromes. Okay, so that's your medical lesson for the day for how we think about things. Just when you thought it wasn't complicated, it's going to get worse. No, I'm kidding. All right, so let's look at the classification tree and what happens for how we go down the list of trying to drill down what you might have. So first you go through the online calculator, and you see on the top that you must have a probability of greater than or equal to 55% for purposes of classifying these diseases. Then we look at the age. So again, back into our calculator is the age of onset at first symptom. On the right side of the screen, you'll see that these are all the juvenile myositis, either juvenile dermatomyositis or other myositis than JDM or juvenile dermatomyositis. We won't talk about that today because I believe that it's mostly adults in the room and we're talking about adult myositis today. On the left side of the screen, we ask for the typical rashes of dermatomyositis. If you have them, then we say, do you also have muscles involved? So you either have amyopathic dermatomyositis, where you don't have your muscles involved and just skin, or dermatomyositis, where the skin is involved and the muscles are as well. For the purposes of this talk today, I'll ask your eye to go to the far left of the screen, where we'll say that the rash was not present. And then we ask for specific clinical features. And what clinical features those are proximal muscle weakness or muscle biopsy features, like those lymphocytes, like the white blood cells that we talked about. If you have clinical features that suggest that you are, the clinical features here are distal muscle weakness more than proximal, and whether you have no response or poor response to immunotherapy, immune blockers, or muscle biopsy features like rimmed vacuoles that we talked about, you would be in the IBM criteria, inclusion body myositis. If you don't have those features, that's where we go down into quote-unquote polymyositis. This criteria does call it polymyositis, but lumps in immune-mediated necrotizing myopathy as well. So the biggest bucket of, that we would fall into on the left side of the screen would be PM, IMNM, and IBM, all those acronyms. And we'll talk about maybe how to tell the difference there. Okay, here we go. So polymyositis, the concept of a rare disease. What I'll discuss today isn't new news. Neurologists have been telling us for 15 years that they think that polymyositis may be rare. Some of you may have heard about this editorial, and I'll tell you a little more about the original study that it refers to, but I do like the title. It's catchy. Unicorns, Dragons, Polymyositis, and Other Mythological Beasts. Oops, let's go forward. What does that mean? Well, the authors of that study said that there was increasing evidence that the polymyositis of the past includes a long list of disorders, and that actually true polymyositis is rare and the least common of the major types of myositis, of the inflammatory myopathies. The article that I'm going to show you is by Vandermeulen and colleagues, addresses the matter and adds evidence to the growing skepticism about patients with this diagnosis. So this was the original paper. Again, this was also in 2003. It takes about 15 years for doctors to come around and try to, answer these questions. I don't know why we're slow to come to update science. For whatever reason, it's taken us close to 2 decades. So these authors performed a retrospective follow-up study of 165 of their patients with a previous diagnosis of myositis, subacute onset of symmetric proximal weakness, just like we would expect in polymyositis, and an evaluation between the years you see here. So they looked at people for 20 years, 21 years, excluding other neuromuscular disorders. These were neurologists, so they said, well, let's rule out anything else that we eventually found that these patients had, ALS or something else that would be not included in these criteria. In this category. So 32 of the patients, or 19% of that sample, were assigned to the possible myositis category. Remember, those are the Bohen and Peter criteria way back when that said you only needed 2 of those top 4 criteria, and this is a little murky. The biopsy specimens of those patients showed a necrotizing myopathy, right? No inflammatory cells. It's called an inflammatory myopathy, but the inflammation doesn't come from those little lymphocytes, those white blood cells that we see in typical polymyositis. And it would be in the vicinity of necrotic fibers. The word necrotic means cell death. So these are muscle cells that are dying because the immune system's attacking them. They actually get regenerated over time, but there is a lot of cell death on those muscle biopsies that we see under the microscope. So the conclusion is that polymyositis is likely overdiagnosed and rare. And I won't lie to you, this was met with uproar, and I sort of feel like it was West Side Story with rheumatologists on one side of the room and neurologists on the other side, and we're arguing. And anyway, so I think we're all coming to get to the point where we're starting to agree that maybe the neurologists were right. What does this look like? So histology is the medical term for tissue. So histologic comparison. You don't have to be a pathologist to see that the left and the right doesn't look like each other. You know, I date myself sometimes when teaching, where I say that in the public broadcasting used to have which one of these is not like the other. I think it was the electric company. It was this great show, and they'd show these pictures. And I always sort of think about that when I look under a microscope. Which one of these does not look like the other? Well, there are not 4 here, but there are 2. On the left, you can see these little purple cells highlighted in the center of that image. Those are lymphocytes, and they are surrounding but not invading a normal myofiber, a myocyte. Okay, so this is primary inflammation, a normal fiber surrounded by inflammatory cells, but they don't invade them. On the right, this is the absence of those little purple cells. The purple that you see on that slide are actually the nuclei of the muscle cells themselves. These are not white blood cells. These are not lymphocytes. They are in the connective tissue, and they are present where they should be in the surrounding part of the muscle. Nuclei and muscle cells are actually in the periphery. They're not in the center of the cell. For those of you that remember biology way back when, where our nucleus, the little nucleus of the cell, is usually in the center, and muscle cells, they're on the periphery. So there's prominent muscle fiber necrosis. You see big cells, little cells, cells that stain blue and cells that stain red. So this is suggesting that they're dying and being regenerated. So in medical terms, this is a sparse inflammation, sparse inflammatory infiltrate, nothing around the muscle cells. Peri means around, perimesial. And then there's something called MAC, which is the complement system in immunology. Our body attacks foreign invaders in different ways, and even our own immune system. Something called complement is activated in these diseases, and it deposits on the small blood vessels that are around these muscle cells. Okay, complicated, but just to say they don't look like each other, right? Okay, I'm not going to spend a lot of time on this, and I really do want to spend a bit of time speaking to all of you or typing my answers to your questions. I'm sorry about this little blue thing on the right side of the slide. I don't know where that came from, but I didn't write it there, so I apologize. So this is what immune-mediated necrotizing myopathy looks like. It looks exactly like what you'd call polymyositis. So the clinical criteria, look, it's these people over the age of 18 with a subacute insidious onset. Myositis generally doesn't develop in a day. Some people will tell me the hour they got sick. Most people will say, you know, I definitely knew something wasn't right. It got worse and worse. And that's what happens in this disease as well, immune-mediated necrotizing myopathy. And you have symmetrical, on both sides the same, proximal weakness, and neck flexors are greater than the neck extensors or the distal muscles, right? That looks exactly like we talked about with polymyositis. You have an elevated CK, so your muscle enzymes go up. You have this EMG findings we talked about, the electromyogram with this irritable myopathy is with all those terms there that medical jargon just says, look, you have irritability in your muscles. You can have a muscle MRI that shows fluid in those muscles, which suggests that there's inflammation. And then myositis-specific antibodies. And those are helpful. I'm going to show you a picture in a moment just of how we think about antibodies. But really what makes the difference is the muscle biopsy, and I just showed that to you. So the muscle biopsy looks very different, and it's important for the pathologist to tell us which one the patient has. Okay, next. So clinically speaking, what do patients with immune-mediated necrotizing myopathy present with? Very similar to polymyositis clinically. Can look like dermatomyositis without the rash, and they have proximal muscle weakness. Generally, those folks have higher CKs. We're talking usually in multiple thousands. Both the overlap syndromes and those mimics and things that look like polymyositis, they're lower than 1,000 on average. Like I said, everybody can be their own individual, but we often see multiple thousands. Myalgias is the medical term for muscle pain, really kind of aching pain. Several patients describe a band-like ache to me. Muscle atrophy, we usually don't see atrophy in these diseases early on, but this particular subtype can see that. And you can have more functional disability in some than we would predict should usually be present. The muscle biopsy is the important feature in making the diagnosis. I just told you that. They have much more prominent cell death or necrosis and a paucity or few of these white blood cells called lymphocytes. And the extensive necrosis might explain why these levels of CK are so high. We think that probably your muscle cells have to die to leak all that CK into the bloodstream. So this is very confusing. You can have a little bit of cell death on your muscle biopsy and not have this particular subtype. But when this is the dominant feature, when cell death and necrosis is the dominant feature, that's when we start thinking about IMNM. Okay, I told you that it was rare. What kind of things should you be thinking about? Should my fellows and clinicians be thinking about? So of those referred for polymyositis, immune-mediated necrotizing myopathy, I think we've beat this to death. I'm happy to talk about it more, but I think you see that that's a pathologic difference under the microscope, and it may be associated with very specific antibodies, which I'll show you in a minute. The antisynthetase syndrome, I'm also going to show you. So if you don't have the rash of dermatomyositis and you have several cardinal features of the syndrome, many people would just say you have polymyositis plus lung disease, polymyositis plus arthritis, polymyositis plus the antibody Jo1. And that may be true. We believe it's better to call this the antisynthetase syndrome with or without a rash. Okay, so I think that's what we're aiming for in the scientific community, many of us, so that we can better generalize people into one category. Why is this called antisynthetase? And those of you who have heard this now, we use this term. Synthetase is, ACE means enzyme, and a synthetase enzyme is in the human body is responsible for helping to make larger proteins. It synthesizes. It's an ACE that synthesizes, an enzyme that helps synthesize things. Why does your body target that enzyme, a synthetase? We don't know. It doesn't affect the target, the protein target of the body itself. So these proteins are responsible for just essentially making chains of bigger proteins, helping take amino acids off what's called a ribosome onto a protein. I can't explain to you why your body chooses that as a target, and it doesn't seem to affect that protein. Okay, and I'll show you pictures of this so to keep you with me. I know this is very sciencey, but I know this audience is also very, very good, so I want to make sure you're challenged. There'll be no test at the end, though, I promise. Inclusion body myositis. We talked about the fact that is sometimes diagnosed as polymyositis mistakenly. I will go on the record today to tell you that I have now, over my career, had a full 180 to this diagnosis. I really used to believe that this diagnosis was always missed and we were just better at seeing it. And that's still true. I think we're still good because we do this all the time. And there are people that get labeled as treatment-resistant polymyositis. I get very nervous when no treatment works for polymyositis, nothing. That is that's the half the story. So folks get the wrong diagnosis. In fact, they've always had distal muscle weakness. They can't flex their finger flexors, so that would mean that it would be maybe difficult to write, might be difficult to do activities of daily living that would require you to flex your hands, your fingers. But there are some folks that start off looking very much like what we have always called polymyositis, and they morph into this diagnosis. So I now teach my colleagues that you should be looking for distal weakness, the weakness of the finger flexors and ankles, in anybody that has a, quote, polymyositis diagnosis with no known antibody. It's not the first bullet. They're not in the second bullet, right? They don't have any of the first two diagnoses on this list, yet they look polymyositis-like. Okay, so anybody without any of these other diagnoses on this list, with that diagnosis, I watch over time, and I'm starting to believe that there are people that may have an overlap or a gradual morph, if you will, into inclusion body myositis that previously really did not show those features. Again, that's my own. That's completely evidence-based. There's no evidence, but I'm hoping that one day we can show you that. Next is overlap. I led in with that one of my very first slides to tell you that there are three diagnoses that we should think about: scleroderma, lupus, and true rheumatoid arthritis. Many people have a rheumatoid-like arthritis. Most of the time, why we call it RA versus no RA. Rheumatoid arthritis, technically speaking, usually is associated with a rheumatoid factor or a CCP antibody. These are specific blood tests that tell us something we call seropositive rheumatoid arthritis. And when the arthritis is the dominating feature of the illness, we feel like that is more like an overlap with two diseases side by side. When the arthritis is a definite debilitating feature of the illness, but you have lung disease and you have myositis and you may have Raynaud's phenomenon where your hands turn blue in the cold, that's syndromic, and that is more likely to be less of an overlap and more in a syndrome per se. Then lupus and scleroderma can also feature here. There's an antibody called RNP, or ribonuclear protein. Some people have what's called mixed connective tissue disease, or MCTD, and that is another overlapping syndrome that can in fact have features of all of these up here. So scleroderma, lupus, and actually myositis, those three can feature along with the scleroderma and lupus features can be seen clinically along with the myositis, and that's called mixed connective tissue disease, or RNP positive myositis. And then finally, it is not, although it's rare, it's not impossible that certain muscular dystrophies, and again, that's out of the scope of this talk, but there are certain muscular dystrophies that have a lot of inflammation, look just like that polymyositis biopsy I showed you on the left of my screen a few slides ago, and is actually an adult dystrophy. So then we have to do special stains, put our heads together with the pathologist, and try to rethink if we've missed anything. This is the antisynthetase syndrome in pictures. It's present with a fairly arthritis. You can see what we would almost call this dactylitis, little sausage digits in the fingers, fever, this idea of mechanics hands, a roughening of the palmar surface and the radial surface of the palm of the fingers, which means it's on the side of the thumb. Usually we see the mechanics hands more on that side, although it can, in this picture you can see it's on the distal, the tip of the finger throughout the whole finger. Raynaud's phenomenon might not be that severe. Sometimes it's just a bluish discoloration, and that's likely a twitchiness to the blood vessels in our hands. Sometimes our nose or our ears or our feet can have Raynaud's as well. This is a French term, but it was named after a specific person who described the phenomenon. It can happen not in cold as well, in times of stress, for example. In the middle of the summer, people still have Raynaud's phenomenon. And then interstitial lung disease. So it's the same inflammatory process that hits our muscle can hit our lungs. You don't have to have all 5 clinical features to have this syndrome, but you do need one of the antibodies that I'll show you in a minute. You can have just the arthritis and the muscle. Some people don't have the muscle. They actually just have mechanics hands and fever and arthritis. So this is really a syndromic disease. But if you have the myositis in addition to the other 5 features of these, that is most certainly the antisynthetase syndrome under most circumstances. Just very briefly, this is inclusion body myositis. This is disease usually of an older population, generally over the age of 50. I don't like that it says elderly. So over the age of 50, you must be over the age of 30 for that diagnosis. Proximal muscle strength loss, muscle atrophy. And I just have a little guy there to show you those are the muscles that are affected. It can also affect women. But this is the one disease that's flipped. Most of our diseases in rheumatology are women dominated, and that's true of myositis. It's about 3 to 1 women to men. IBM is 2 to 1 males to females. You can get the scooping of the forearm, meaning that you lose the forearm where you have usually a nice rounded hump where it would be essentially concave out. You have like a convexity where you have loss of that forearm musculature in the forearms in particular. These are the people that get labeled as treatment-resistant polymyositis, and we love to be able to see inclusions on specific staining on the muscle biopsy. Okay, so, and these are the muscular dystrophies. I'm actually going to skip this for purposes of today. What do you want to know about antibodies? Again, busy slide. I just bring this to show you that myositis is not very old. It was first described in 1877 by Wagner, a German physician that described this phenomenon of polymyositis. Unverricht was a colleague who described dermatomyositis and then separated it from polymyositis a few years later. So 1891 occurs, and then nothing is really known until 1980 when the antibody Jo-1 was first discovered. And then there is an explosion of autoantibodies. Since I have been in the field, I think we've doubled the amount of autoantibodies that we understand to be true. And again, that's an entire hour talk on its own. But I'll leave this slide up for a little bit of time. I think it's an important one. It's not perfect. I think that there are some, there are definitely some changes over time. But in general, I think you can see that different antibodies keep in their sphere with different features of disease. For example, malignancy is more likely. You don't have to have malignancy if you have the antibodies to either of those two things there. But NXP2 and TIF1, these are very common antibodies, so I don't want you to panic if you have one. It's certainly 38% of our patients have an antibody to TIF1, which is also called P155-140. Those antibodies are common, but if someone has cancer and you check the antibody, it's more likely to be one of those two. And we're learning a little bit more about some of the other cancer autoantibodies as time goes on. Certain antibodies confer much more specificity to lung disease, or if you've been exposed to a statin, you may have the HMG-CR antibody to the left of the screen, and this is the antibody that we discovered and described at our center. Anti-SRP is a particularly tough antibody to treat in some cases, not everybody's. In my hands, I definitely would say that's one of the hardest ones that I treat. And interestingly, we've shown that maybe certain treatment protocols may benefit certain antibodies, and others have shown this as well. For example, rituximab, something we might reserve for third line or longer, might be best to be first line for some of the severe myopathies like those associated with SRP, and that's a necrotizing myopathy. Anyway, lots of data, certainly even at the level of a scientist that does this for a living, this is confusing. So I don't expect you to know this all in 40 minutes, but I just wanted to give you an overview about how sophisticated the field has really come over the last decade or more. Here's autoantibodies in cancer. Now, what that means is frequency of cancer association. This does not mean that 60 to 80% of the people with that antibody have cancer. I'm going to repeat that. This is not true. It means that of the folks who have cancer, 60 to 80% of the time, it'll be associated with that antibody. I want to hear that loud and clear. And the same is true for anti-NXP2. And we're even noticing that in other cohorts, the antibody that's often associated with statins, it can be associated with statins or not. And it's somewhere around 13% of the time we're seeing that antibody associate with cancer. So stay tuned, we're still learning there. Okay, I'm going to actually go back. There's one other antibody I want to talk with you about. This is one of the newest ones on the block. This was described relatively recently, and it's called SAE, or AntiSMO, small ubiquitin-like modifying enzyme. For the purposes of this talk, I'm going to not belabor it a lot because this is exclusively associated with dermatomyositis, not polymyositis. But it is an up-and-coming antibody that I think we need to keep on our radar that may be associated with malignancy. Why do I bring these antibodies to your attention? Why does it matter? Perhaps we don't have to screen everybody so diligently for malignancy forever. Perhaps we can screen only a small cohort of people for a short amount of time and reduce anxiety. I do realize that, having this antibody may create anxiety in some, but I do bring it up as an important thing to discuss, I think, with your physician to make sure that an adequate workup has been done at least once. Okay. This is my team. I always say that, it takes a village. I don't work in a vacuum. And these are all the players at our Myositis Center. And I sometimes call this the age before beauty slide. Jerry and others may have heard me talk. I'm not aged, right? So this is on the left of the slide, and that's me around 37 years old, and I'm going to stay that way until I have a better picture. So for now, that's me. Dr. Andy Mammon, who's been my partner in crime for many years, he and I have co-founded the center initially along with Dr. Sonia Danoff and the Pulmonary Division because a third of our patients do in fact have lung disease, and that's another topic again for another day. I'm sure Jerry has them all on the list, but that's probably a good hour or more to discuss our pulmonary complications. But Dr. Danoff has been incredibly helpful in teaching us about how to take care of these diseases together as a group. And then the other people that you see on the slides, Age Before Beauty, the younger good-looking set down the bottom, are our junior colleagues who are actually not so junior anymore. They have all been here for a long time as well, representing everything from neuromuscular, physical medicine, rehabilitation to neurology and rheumatology, and then pulmonary medicine. And then finally, Dr. Cassiola Rosen on the top is actually one of our bench colleagues. She helps us really look at those antibodies, trying to discover new ones and trying to hone in a little bit more to be more specific about these diseases so that we try to treat them all similarly. So with that, I've left a few minutes for questions. I hope it's been helpful. I recognize it's a whole lot, and I'm happy to take any questions. Thank you.
We did have some questions that were submitted earlier. Valerie had listed a question: how does the diagnostic criteria change with pre-existing mixed connective tissue disease?
Yeah, that's a very complicated question. So that essentially excludes that diagnosis because we know what you have. So in mixed connective tissue disease, we would also call that overlap. And again, just like the antisynthetase syndrome, mixed connective tissue disease can have overlap with the features of rash or not rash. So you may have the quote-unquote polymyositis type feature where you don't have a rash, or dermatomyositis. But instead of calling it polymyositis, we feel it's probably more important to call it overlap or mixed connective tissue disease by itself. If you put your features into the diagnostic calculator, you would probably still come up with the diagnosis of polymyositis because many people have those clinical features. But if you know that antibody, which is, you must have an anti-RNP antibody for that diagnosis to be true, mixed connective tissue disease. To have an overlap with other diseases, however, sometimes that antibody is not present, and that's very confusing. So we would just characterize you into mixed connective tissue disease and not put you in the polymyositis bin. Again, it's confusing, but I think it just helps homogenize the group so that if we were to look at you in concert with many other people in a trial, for example, or many other people that took drug A or B, we would want to say, it seems to work better for that group.
The
Sure.
finding that I read a little while back about hiker's feet.
Yes.
How is that playing a role into diagnosing clinical trials or anything like that?
Yeah, so I don't think it's made its way in. I'll give you a very, very quick, you guys will know the backstory. So mechanics hands has always been recognized, but we started to notice that people would complain of a very similar phenomenon on the feet. I am privileged to teach in the medical school or give clinical correlations to the medical students. And one of my dear patients came in to tell her story, and she mentioned the mechanics hands. Students after that lecture came up to me and said, does this happen on the feet? I said, yeah. I said, we sometimes call it mechanics feet. They said, that makes no sense whatsoever. You need a better term. So instead of mechanics feet, they said, how about hiker's feet? I said, well, that's definitely better. So that's why you need young people to work with you. And so we just did a very sort of a systematic review by reviewing the medical records that we had, but we haven't evaluated for that prospectively, carefully in every patient yet. I think it's likely in the same realm as mechanics hands. It seems to have an immunologic feature where it's difficult to treat. It's a scaly rash, and it may eventually be a correlate where it'll say mechanics hands or hiker's feet one day in the criteria for example, the antisynthetase syndrome. Right now it's so new, so it hasn't been incorporated yet, but we're looking more carefully at the feet. I think as physicians, sometimes we don't always go that far, or in a quicker visit, we don't take socks and shoes off, but as physicians that examine the skin, I think that the feet really tell us a lot. So stay tuned. I think I'll have more information for you as we look systematically over time.
I guess the top primary, we know that that IBM really doesn't have any approved treatment. Some things may work short term, but I've noticed that there have been reports that they may have long-term bad outcomes.
Yes.
As a result of the treatments.
Yes, I think what you're referring to, you're one of the most knowledgeable people, so I'm assuming that this is the data you know, is that there's a French study showing that prednisone exposure can be associated with increasing mortality in IBM patient cohort. I think that you have to take that with some trepidation in that possibly that's confounded by the fact that maybe that particular cohort of patients was weaker and therefore received therapy more often. So I don't know that we can separate out as a confounder. Again, it wasn't evaluated systematically. I will say in the field, we probably all try prednisone once in everybody to say, hey, do you have a response to that or not? Sometimes that in itself is a test to help us say, wow, okay, that's less likely to be inclusion body myositis. But we try not to treat people with immune suppressants with IBM because there really hasn't been data, for the most part, shown to be helpful. I'm going to give one caveat to that. I have a few people in this category that their proximal weakness seems to respond to prednisone and their distal weakness does not. So they may be this overlapping phenotype that I'm starting to see, that I do think that there are some people that are not purely one or the other, that they may have this PM, IBM overlappy thing. And I just think we just don't have enough data on that yet. But my guess is that eventually we'll figure out what that is.
And I like the medical term, that overlappy thing. I love that.
Overlappy thing. Do you like that? It's very scientific.
It is. Thanks for explaining that.
Sure.
We have a patient that has PM along with sclerodactyly.
Yes.
Fingers are involved, no antibodies, baseline restricted lung function. And I know this is getting a little personal, she wants to know, should she be overlap versus polymyositis?
Yeah, so I would call her scleroderma myositis overlap. I think that's right. I too have a gentleman I've followed for years who clearly has a little scleroderma overlap as well, very similar to what she describes, and no antibody known. So I would say that's not that you don't have an antibody. It's probably just one we haven't found yet. It's a rarer one. The reason to know that and to call you a scleroderma myositis overlap is that in your situation, I would follow your lungs closer. So pulmonary function testing every 3 to 6 months, 3 months if they're changing. Many pulmonologists will do them 3 months anyway, but a minimum of every 6 months, and a 2D echocardiogram every year, because you have a slightly increased risk of something called pulmonary hypertension, high blood pressure between the heart and the lung circuit. So it's, like I said, it's less of an academic or a semantic exercise. It actually really has potential, I think, prognostic implications as to what we call these things.
How precise are the antibody tests, and what's the risk for false positives?
That's a very hot topic. I'm telling you, you have the smartest audience. I know it. So how precise are they? We used to think pretty precise in certain labs. I will say that I will leave it at this. This is an evolving question. I do think that all of us who concentrate on these diseases for our clinical and research practice, realize that we probably have to have more specificity. There are false positives in some of these. There are more likely false negatives, though, than false positives. So I think what I would say is, in the hands of an experienced physician, taken together with the sum total of what people look like clinically, I think it's very important to take that in concert with the antibody. Where I question an antibody is when their clinical features don't seem to match the antibody. So I showed you that big, giant looping slide where things overlap with each other in big Venn diagram circles. When it doesn't look like it fits, that's when I reinvestigate.
Thank you so much for joining us, and thank you for your time. I know that you have just a loaded schedule, and certainly appreciate it.
I will thank you for all you do, Jerry. I know that your heart and soul is in this, and my favorite thing to do really is to take care of people. And so I'm very grateful to be able to reach a lot of people in just a short time today. So thank you for the honor of being here, and I'm always happy to help.
Thank you so much, Dr. Lisa. Enjoy the rest of your day.
You too. Bye, everyone. Have a wonderful afternoon and enjoy the sunshine.